Morning again. Jadi, I will continue from Dr. Atikah. Jadi, saya akan membentangkan tajuk ni lah, management of postpartum hemorrhage. Jadi, this lecture actually there's a overlap lah between mine and Dr. Atikah sebab I think Dr. Atikah will mention a lot of aspects regarding management also. Tapi I will concentrate more on medical and surgical management and conclude. So, as all of you all know, medical management is one of the vital importance in managing postpartum hemorrhage. Because if you fail in medical management, then we have actually generally failed in managing it because you have to intervene by surgical management. Because if we can actually arrest the bleeding dengan medical management, then we can actually avoid further morbidity. So, principles of managing postpartum hemorrhage, so macam Dr. Atikah cakap tadi, is early identification. Kebanyakan kali postpartum hemorrhage kita ni is identified quite late, and at the same time it's underestimated loss. The main reason is because the loss is underestimated. By the time patient by the time we recognize there is actually a bleeding, patient must have at least lost about nearly to 1,000 liters. And when talking about symptoms as well, when patient is recognized to be pale, she must have at least lost about nearly 1.5 to 2 liters. And as you all know, macam Dr. Atikah mentioned tadi, kalau tachycardic, it's about at least 1 liter, and also reduction in blood pressure is about 2 liters. Prompt action is required. So kalau there is early recognition, to immediate action should be instituted in terms of teamwork. So you cannot manage postpartum hemorrhage alone. Okay, that is the main aspect of managing postpartum hemorrhage. Kalau if you recognize as a postpartum hemorrhage, you must work as a team. That is very important. That is why we have instituted a red alert system. Kita ada red alert system which is supposed to be implemented all over, in fact all hospitals. Hospital dengan pakar atau hospital tanpa pakar. So in hospital berpakar tu actually you will see that all the team will consist of all the ONG specialists, consultants, specialists, medical officers who are actually on call. And sometimes you may even get the people who are not on call pun kena datang juga lah, kena assist, anesthetic, doctors, medical doctors, sister on call, blood bank. These are all very important people. Blood bank people also have to be alerted because kita perlukan darah. Sometimes the blood, as Dr. Atikah was mentioning, is very vital. Replacement of blood is very vital. So you must inform them saying that there's a crisis in labor room. So in hospital tanpa pakar pula, we must get the pengarah di luar. So the red alert team should actually consist of the doctor on call, the first and second call, the sisters on call, the ME on call, the pengarah hospital. Okay, so they must come as a team. And once red alert is triggered, all of them must come to the hospital, and all of them must come to the labor room to attend this patient. And once once the patient is relatively stable, the cause of postpartum hemorrhage must be identified and managed appropriately. Umpamanya kalau obviously there's an atonic uterus, it must be recognized, and the initial investigation, initial management must be instituted early. Kalau there is a tear, katakan there is a trauma, so we must actually work towards inhibiting ataupun arresting the bleeding by taking her for examination anesthesia, the OT, and repairing the tear. So the other thing is we need to stabilize the patient as immediate as possible by taking all the steps to prevent further bleeding. So resuscitation we have gone through. I think everybody is singing the same tune from morning. Resuscitation is ABC, airways, breathing, and circulation. We want to drum this to your head because you must know the basic principle of resuscitation. Meaning patient can come to you referred. Maybe she might have delivered at home ke ataupun delivered in district hospital, coming to you with altered sensorium. Okay, so that will affect the airway. That can block the airway. So you must know how to actually make sure that we have got a patent airway. Okay, breathing is important as well as circulation. Circulation, we will be teaching you all what are the important aspects of circulation. Initial resuscitative measures. Okay, we must again determine that we institute ABC, determine the patent highway, and adequate breathing. Okay, kalau patient is unconscious, sometimes we may have to intubate. Okay, intubate. We must make sure that there's no obstructions. We must still head to the site. The patient is unconscious, and oxygen, high flow mass oxygen must be given about 6 to 8 liters. These are the initial resuscitative measures for airway and breathing. Then circulation, you need to correct the circulation, you must correct the hypovolemia as well as hypotension, the minimum 2 large lines. You must take blood for investigation, full blood count, cross-match, coagulation profile, stabilize the patient with crystalloids or colloids. I'll talk about the fluids slightly later. Transfuse blood immediately. So our main objective is to get blood. Okay, before the blood arrives, we can actually start giving fluids. So that is the reason, kalau kat labor room tu, we need blood, we send the houseman running, we ask them to run. We don't even give the PPK to go because we need the blood immediately. So our housemen are like Superman, they can do everything. They run means they run immediately to labor room, to blood bank, they wait for the blood and they immediately take blood and they bring it, run and bring back to either OT or labor room. So this one I think we've gone through already. So as you all know, the critical part is kalau patient, kalau there's a loss of more than 1 liter, you realize the BP starts coming down. Okay, kalau about 1.5 to 2, in fact you can see the blood pressure is also coming down. Kalau more than 2 liters, the BP, the systolic blood pressure will come down, and patient will have some altered consciousness. So this is very vital. Kalau you tengok BP already dropping, you know that the blood loss is about 2 liters already. Okay. The patient is going away from you. So you must make sure that everything must be done immediately. You must replace the volume as much as you can by blood. Okay, let us talk about the type of fluid. Tadi kita dah mention pasal crystalloids and colloids. So the most important fluid which we can replace immediately is crystalloids. Okay, crystalloids are very vital. It's actually easily available. So to replace immediately, we can use saline Hartmann. Okay. So when we talk about immediate replacement, crystalloid is the fluid which you need to use. Tapi kalau if there is a slight delay, katakan, let's say of getting blood, we need to expand the volume, then colloid comes into play. But colloid you can't use it for a long time because it doesn't contain anything else. It only contains some form of fluid as well as sometimes it may have some form of gelatin, so albumin and so on. So it will expand the volume, but it doesn't give any form of oxygenation. So you must understand that. So all these are temporary measures. So eventually blood is actually the answer. We need blood. Okay, that's the most important thing. Determining the cause. Okay, so always remember, cause must be determined once the patient is stabilized. So you must ensure that it is not due to either one of these. So you remember it's 4 T's. Tone, meaning abnormal uterine contractility, which is atonic uterus. Either it's retained POC, whether it's a tissue, it can be actually a retained POC. Genital tract trauma can be a cervical tear, uterine tear. Or it can be rarely due to abnormal coagulation, which is due to thrombin. So it is important that we identify what's the cause. Sometimes there can be coexisting causes, meaning that patient can have uterine atony because there is an extended tear. Sometimes the uterus may not contract very well. So it can actually present as a uterine atony as well. So we must make sure that we identify the cause, exact cause. Okay, we will focus on management of uterine atony. So after the general measures, as we did mention earlier on, we will institute the initial measures macam uterine massage and bimanual compression. Dr. Atika had mentioned just now, how do you actually do a uterine massage? And you manually do a bimanual compression. So this is a temporary measure because it will actually stop the blood, relatively reduce the blood to the uterus and eventually will form some form of compression which will reduce the bleeding. But this, you cannot do it too long. This is a temporary measure and it can be quite painful on the person who's doing it because you can imagine you're putting your hand there for such a long time. As far as medical treatment is concerned, of course, oxytocin. Oxytocin is very important. We can start on infusion, which is about 40 units in 500 mils of normal saline, running at about 40 drops per minute. We can use symptometrin or ergometrin, but always remember ergometrin, you must be a bit cautious in patients with hypertensive and heart disease. So you can give symptometrin, about 1 milligrams, and you can repeat at 15 minutes interval to the maximum of 2 to 3 doses. Usually we can go up to about 3 doses. We also have the option of using carbopros atau prostaglandin F2 alpha, is hemabate, known as hemabate. Can use 250 microgram intramuscular, kena pakai intramuscular. Repeat every 15 minutes also. Maximum to about 3 doses. You can even go up to about 2 milligrams sometimes. So these are the medical treatment which you need to do. So maksudnya you can simultaneously start on IV infusion of oxytocin and give symptometrin, and following which kalau there is a failure you can even proceed to carbopros. And these are the if all these medical measures fail, then we have to consider surgical intervention. So these are the medical drugs as I was mentioning earlier on. Kita tengok oxytocin di sini, oxytocin. So you can give by infusion. Here is mentioned 20 units, but even you can go to about 40 units. Ergometrin, but always be careful because in hypertensive patients. Okay. We can also use carbopros. You can even give intramyometrial kalau kita intramuscular. Apart from that, the other option is kita boleh bagi direct intramyometrial. The other options which we can consider in some countries is using misoprostol, like in third world countries, developing countries. They use misoprostol, intrarectal misoprostol. Maksudnya they put 1 or 2 doses of misoprostol and they repeat every 20 minutes. But the problem with this is kita pakai misoprostol ni, they cause a lot of side effects and they akan muntah, vomit. But this is very convenient because it comes as tablet. Okay, so no need to set line, no need to give injection. You just put a tablet. And nowadays, we are getting good results with tranexamic acid. Tranexamic acid, kita bagi intravenous tranexamic acid, and you realize that it actually gives good results for postpartum hemorrhage. Satu lagi adalah factor 7. Factor 7 ataupun Novo 7. This is very expensive. This actually gives, it's actually replacing factor 7, and this factor 7 is very important in the coagulation cascade. And you realize that once you start giving factor 7, the bleeding will stop. Okay, from medical, we'll move on to surgical management. What are the surgical management available? Kita ada surgical management, and some of the surgical aspects of managing postpartum hemorrhage is we need to preserve the uterus. Preservation of uterus in terms of surgical management is you can actually have in form of internal uterine tamponade, kita pakai balloon and so on, or hemostatic suturing. These procedures will preserve the uterus, maksudnya we don't have to take out the uterus. The other thing is bilateral internal islet ligation or hysterectomy. Okay, so bilateral internal islet ligation can either you can preserve the uterus, at the same time you can do the internal islet ligation, or even after the hysterectomy pun you boleh buat internal islet ligation. Okay, when we preserve the uterus, maksudnya the patient can in future get pregnant. Okay, so meaning that in certain instances macam you want to preserve the fertility, maybe primary gravida ataupun mother has got history of infertility after delivering the first child and so on. So maybe we want to preserve the uterus, so we can try to use this surgical methods lah, macam uterine internal uterine tamponade. Maksudnya kita nak we want to give some form of pressure inside the uterus so that we create a tamponade. So kita boleh pakai uterine packing, balloons. Balloons ada banyak jenis lah, macam Beckley, Celestine Blackmore, rush hydrostatic catheter and so on. So these are some of the procedures yang kita boleh pakai for tamponade, to create a tamponade inside the uterus. The other surgical method yang saya mention tadi untuk uterine preservation is kita pakai suture. We use a suture and we tie the uterus so that the uterus actually will be compressed, and that will reduce the bleeding. So kita boleh pakai B. Lynch suturing. This is B. Lynch is the guy who came up with this idea of suturing. Atau the other methods are Heyman suturing and Cho multiple suturing. Okay, and also bilateral internal islet ligation. The other method is hysterectomy. Can be either total hysterectomy ataupun subtotal hysterectomy. So uterine packing. Uterine packing is actually an old method, relatively old method. Kita tak pakai dah sekarang ni, not so much lah. Because it can be a bit of a hassle. We have to pack the uterus dengan roller gauze. Okay, and sometimes it can be quite tedious. So it is applied directly inside the uterus, and it is applied to the capillary or the venous bleeding is oozing within the uterus. Masalah dengan ni, sometimes when you use this, sometimes the bleeding will be ongoing. Okay, and there will be a delay in recognizing continuous bleeding. And there's a risk of trauma as well as infection because you are introducing a foreign body inside. So kalau macam tu, there is always, when you keep pushing and pushing, there's a risk of further trauma, kan? And you leave it longer, it will introduce infection. Balloon, okay, kita boleh pakai tamponade. You can use this balloon known as Beckery's balloon, which is quite popular instrument, popular method nowadays, where what you do is it's like a catheter, uterine catheter, kita masukkan ke dalam and you inflate. So it will occupy the entire space and it will cause compression on the endometrium. So that will decrease the bleeding from the bleeding points. So this balloon can be inflated up to 500 ml of saline. And you can even do it muscle cesarean section. So this is how it looks like, the Beckery's balloon. There are other balloons as well, so second Blackmore ataupun rush balloon, we call it. Okay, suturing, saya macam tadi suturing, uterine hemostatic suturing is Behling suturing. So the aim is actually to exert vertical compression on the uterine vasculature and muscular system. So this is mainly when the uterus is involved, so kita boleh buat. And it can be done during the cesarean section, okay, ataupun after delivery. Even after delivery, vaginal delivery, kalau still bleeding, you can take the patient to OT. Dia orang akan we open up, then lepas tu we can do this Behling suturing. What do? We actually put the sutures around the uterus. I won't go into the details lah. Just for your information, kita keluarkan uterus, we externalize the uterus, and sometimes if it's open uterine cavity macam Caesar tu, kita masukkan jarum ke dalam, we just bring it out, and then we use another suture and you just bring it out again and you just tie it in the center. Okay. So this is the original method of Behling. Kita boleh pakai sutures which is either monocryl, bicryl, or sometimes you can boleh pakai Mercelin sutures, Mercelin tapes. The maximum effect is about 24 to 48 hours. After that, what will happen is sometimes the tensile strength is not there anymore. Okay. So after kita pakai suture tu, dia akan jadi macam ni lah. Maksudnya, it will compress the whole uterus. Okay. So, that will decrease the bleeding. It is effective, simple, and the fertility can be actually preserved. It's cost saving. Mortality can be avoided if you do it early, and sometimes you can do it prophylactically at cesarean section when there's eminent signs of postpartum hemorrhage. These are the other alternative lah. Kadang-kadang you just simple things. You can just put suture around it, around the main bulk of the uterus, and just tie, put 2 ties, and here you can actually tie it up. So there's a lot of modification of this Behling suture. Bilateral internal iliac artery ligation. Internal iliac artery ligation has been described with varying success, about 40 to 90%, 95%. So what is this internal iliac artery ligation? We actually ligate the internal iliac artery. So the anatomy, just to tell you the anatomy itu, kita ada common ilia, okay, the external ilia, internal iliac di sini. It comes the anterior branch and posterior branch. The anterior branch supplies the uterus. So what we are doing is we are tying the anterior branch of the internal iliac artery. So even you tie the anterior branch and internal iliac artery, you don't have to worry because there's so many collaterals. Banyak collateral. So there won't be any issue of necrosis or hypoxia or necrosis or whatever lah. So because of the major pelvic anastomosis, the vascular compromise doesn't occur. Okay. So I won't go into the details how do you do it, because basically what we do is kita identify the anterior branch. Okay, this is the common, this is the internal, this is the external. This is the internal iliac artery, anterior and posterior. So kita tie off the anterior branch. Okay, so kita tie about 0.5 cm apart. Okay, so indication for internal iliac ligation, can do it prophylactically in certain conditions or as a therapeutic measure, macam continuous bleeding after hysterectomy, or maybe there is actually profuse bleeding because of extended tear dan sebagainya lah. Okay. So you have to be trained. Internal airline ligation ni sometimes there must be skill. Not everybody can do it. You must be familiar with the pelvic vasculature. Sometimes there's a risk of damage to ureter ataupun damage to common or iliac veins. Okay. So should be only reserved when the other measures has been exhausted. Okay, you can't be doing it routinely because this is sometimes it needs a lot of training for you to do this procedure. Okay, hysterectomy. So indication for hysterectomy, these are the various indications: abnormal placentation, abruption placenta, uterine atony, which is not responding to treatment, uterine trauma dan sebagainya lah. So the surgical principle masa peripartum hysterectomy is you must to take, always remember the ovarian vessels all enlarged and distended, so that will cause a bit of problem with edematous. Lepas tu kan, one more thing is the vascular pedicle might be thick, so you kena pakai clamp, 2 double clamps and also double sutures. These are all important principles. So sometimes it can be difficult, especially when hysterectomy is done when Olss is full. So sometimes it can be very difficult to identify the cervix. So these are the few points for surgical principles for hysterectomy. Okay, the type of hysterectomy, kita ada total abdominal hysterectomy dengan subtotal. Perbezaan dia adalah total tu actually we remove the cervix and paracarpus together with the body. Okay, macam ni. Whereas subtotal is to actually we leave behind the paracarpus as well as the cervix. We only take out the body of the uterus. Right? Eventually it's like this lah. This is the subtotal hysterectomy. So a subtotal is usually is safer and faster and easier to perform. Okay, will need less blood transfusion. So subtotal sometimes in terms of, let's say, speed tu is better lah, and less blood transfusion. This is how we do it. Lepas tu kita cut di sini. So the cervix will be left behind. So kalau kita tengok dia punya procedures tu, so if you talk about hysterectomy, of course their fertility status in future is not because uterus is taken off. Whereas B-Lynch dengan internal artery ligation, you preserve the fertility status. Okay, and you must always remember you need training and experience for internal ligation. Not everybody can do it compared to B-Lynch. B-Lynch is relatively easy to perform. Okay, in conclusion, I think as everybody before this have mentioned, early identification and appropriate early management is important. Must do it early. Postpartum hemorrhage can identify early. We cannot actually hold on and just wait and observe the patient. Get help and manage as a team. You cannot manage all by yourself. Refer to hospital with specialists and blood banking facilities. Early referral is very important. We need to have regular training and in-house house drill. Maksudnya drill in labor room. Bukan drill pakai gerudi. It's not that. Drill meaning that we have training. Okay, training every frequently maybe a duration every month tu kita ada one labor room drill. Maksudnya shoulder dystocia drill, maybe postpartum drill and so on, postpartum hemorrhage drill and so on. And regular CME for doctors and nurses. Okay, these are some of the important vital components which we need to know and also we need to be familiar with. Okay, with that, thank you for your attention.